The advancement flap is drawn so that the length is approximately 2.5 to 3 times longer than the width. Care is taken to stay in the subcutaneous plane during the excision of the lesion. Countertraction is helpful during incision and excision. The scissors can be used to undermine as well as to cut the deep layers of the soft tissues. The skin incisions themselves should be made with a sharp knife. Care is taken to incise perpendicular to the skin edges. Again, the entire flap is undermined in a layer between the skin and the deeper subcutaneous tissues. Undermining is continued beyond the extent of the dissection by 1 to 2 centimeters in all directions. This allows for easier flap mobility. The first suture is placed in the center of the flap and out the central aspect of the defect. This is tied with a hand tie and a surgeon's knot to prevent slipping of the knot. By keeping constant tension on the sutures, one can prevent tying an air knot. The suture is cut with a small tail that prevents unwinding of the suture material over time. The corner sutures are placed next, since they are the other primary sites of tension in this flap design. Here an instrument tie is being utilized for the corner stitch. Again, a surgeon's knot is put down on the first throw, and now we have a problem of unequal skin edge length. The skin edge is longer than the flap edge. We will then close this with the principles of halving. The first or central suture is placed in the middle of the inferior edge of the flap and in the middle of the corresponding skin flap. The two halves on either side are still uneven, but less so. Subsequent sutures are then placed so that it splits the difference between the previous sutures until enough sutures are placed for adequate closure. In this way, the redundant skin of the lower flap is spread evenly across the entire wound closure and results in a smooth wound edge. On the upper flap, we have closed it so that the skin is closed in an even manner, resulting in a standing cone deformity at the inferior aspect of the flap. The standing cone deformity excision is always done away from the flap pedicle. A single hook is placed in the dog ear, and the triangle that is formed can easily be seen. It is then marked with a surgical marking pen. An incision is made perpendicular to the skin edge so that we can mark out the point of a triangle. Undermining is done under this dog ear deformity. The skin is transposed back until one can exactly see how much skin is needed to be trimmed. The skin is then trimmed and the flap is inset. This flap is then sutured into place and the dog ear deformity is resolved. Here we can see a circular lesion that's now being excised. We can see also the first flap is already marked, and that's approximately 3/4 to full diameter of the circular lesion to be removed. And you can also see the second flap, which is approximately 1/2 to 3/4 of the diameter of the lesion. And the angles are approximately 45 to 50 degrees along the long axis of the flap. Here you can see the lesion has been excised, and now the limbs of the second flap are being incised. The first flap is now being incised, and that's more circular because that needs to be rotated into the area of the defect. Now a triangular portion is being removed as the remainder of the first flap is being undermined. The reason the angle or triangle needs to be removed at the apex of the first lesion is so that that first flap can be rotated into position. We're undermining the second flap now, actually wide undermining, either with scissors or 15 blade is necessary to allow the rotation. Again, wide undermining The triangle to be removed is also undermined, and the area of the lesion is now being undermined. The triangle is now being excised so that the first flap, as it's rotated into the wound, is not overlapping skin. Now that first suture can be placed at the apex of the flap, or it can be placed here at the peak and the valley of the flap. The order again is not as critical as accurate placement, and here we can see the closure of this apex and valley so that the first flap can be rotated into position. Usually we use a two-handed tie for placing the first sutures in points of tension. Here's the suture being placed at the apex of this first flap, and that is being sewn into position. And now we can begin to see the flaps being rotated into position. Here we can see the second flap that's being rotated into position. That's being closed. If there is a excess at the tip of this flap because of the apex, that can be trimmed off. Another suture is being placed here to close the area of the second flap, the donor region of the second flap, and we can begin to see how the wound is coming together. We use the remainder of the sutures to be placed according to the principles of halving. If any dog ears occur, again, we remove a dog ear by placing a hook at the apex of the dog ear or standing cone, and then use a back cut away from the flap and trim that tissue to allow the flap to be closed. Here we see the circular lesion removed and the first and second flap in position. The fusiform excision is marked with a length of 1.5 to 3 times the width. The intervening skin and soft tissue is then excised. The incision made in the skin edge should be perpendicular to that skin edge. The fusiform to be excised can then be removed with sharp dissection using either knife or scissor. The skin to be excised can be held with a forceps or a skin hook. The middle finger can also be used to aid in the retraction of the soft tissue during the dissection. In order to allow the tissues to come together during the closure, undermining is necessary. When scissor dissection is used, the tips of the scissors are best kept tip upwards towards the skin edge so that the deep structures are not inadvertently cut. A number 15 blade can also be used to continue the undermining. This demonstrates that either a scissor or a number 15 blade can be used to undermine the soft tissues, which will allow closure without tension. The first suture that is placed is a deep suture, and it is buried. It is placed in the dermis at approximately the mid portion of the incision, according to the principles of halving. A surgeon's knot is used to close the deep tissues, thereby approximating the wound edges. Notice how the wound edges come together. The deep suture is cut on the knot, and the wound edges are now well approximated. A second deep suture is placed according to the principles of halving, midway between the first central suture and the end of the long axis of the wound. Again, an instrument tie is used to fashion the square knot. 4 throws are used to be sure that the knot is secure. Skin sutures are then placed according to the principles of halving. The first or central suture is placed midway between the long axis of the wound. Note that the edges of the wound are both approximated and everted. The skin suture is cut with a tail. The remainder of the skin sutures are also placed according to the principles of halving. Here we see the defect. An incision is being made around the defect, and then the limbs of the note flap will be created by making a line as a tangent approximately 1.5 times the length of the diameter. Here we see the lesion being excised. Once this lesion is removed, the other limbs of the note flap are drawn. There's the first limb. It's approximately 1.5 times the diameter at approximately as a tangent. And the second limb is now cut. That is the diameter of the lesion at approximately 60-degree angle. Now the dissection begins at the apex, at the 60-degree angle apex, and it is widely undermined so that the flap can be rotated into the circular defect to close that circular defect. We will have some excess tissue at the apex of the flap that needs to be trimmed. Now, the first suture is being placed, as we see in this example, from the apex of the flap, from the tangent of the circular defect. That's the point of maximal tension. The second suture is now placed. It's placed at the flap as it's being rotated into position. Notice this is a triangle being rotated into a circular defect. So we need to be able to trim the excess of that flap so as it fits and it will inset nicely into the circular defect. Here we see the dog ear. So we place a suture to close this end of the flap. Placing it in position, we can see the dog ear has now been created. We will remove that by making the back cut and then sewing that into position. Here we're now closing the remainder of the flap. You can see there's a triangular excess which will need to be trimmed and inset properly. And again, another suture is placed at the apex of the tissue so that all limbs of the defect are closed. The remainder of the tissues are closed according to the principles of halving. Now we can see that there is this excess. We now will cut this triangular excess off so that the flap will inset nicely into the region of the defect. This can be trimmed off with either a pair of scissors or with a 15 blade. And now the final stitch is put into position to close the wound, and the flap is now nicely in position, closing the defect. Here we have the dog ear. A hook is placed. The line of the back cut is marked. Always place the hook at the apex of the dog ear and always cut away from the flap, so you do not want to interfere with the blood supply. The back cut is now made. We can see using the hook that we have excess, and this excess is now trimmed off, removing the dog ear and allowing the flap to inset nicely into the area of the defect. This is a relatively fast and easy technique to remove the dog ear, and now the sutures, one or two may be placed depending upon the amount of tissue that needs to be closed. The sutures are now placed to complete the closure of the wound. Here we see the excision of the circular defect and the closure with the note flap. The rotation flap is utilized to close a triangular defect. The rotation flap follows a smooth curve from the site of the defect. It then gets rotated into place. Typically, the limb of the rotation is approximately 2 to 4 times longer than the axis of the defect that it needs to close. This is a flap with a very large vascular pedicle, and it is extremely useful for facial reconstruction. Because the skin edges have already been incised, the defect can be completely excised with scissors. The flap is then incised with a knife, broadly undermined under the entire flap, as well as 1 to 2 centimeters beyond the skin edges of the defect. Test rotation can be done intermittently during flap elevation to determine whether the back cut is enough. The key suture is then placed. An instrument tie can be used with this flap design because there is not a significant degree of tension. The flap edge is then closed to the longer skin edge using the principles of halving, splitting each side in half for subsequent suture placement. Now we have an example of the rhombic flap or rhomboid flap on a pig's foot. The limbs of the flap are of equal length, and the angles are again 60 degrees and 120 degrees. The lesion is now excised by utilizing 15 blade and then picking up the edge of the lesion and now dissecting it free with a number 15 blade down to the subcutaneous tissues. Notice also the other limbs of the flap are the same length as the parallelogram of the rhomboid flap. The angles are approximately 120 degrees and 60 degrees, and that's how the other limb of the flap is fashioned. And now the incision is made along the superior limb, and now at an angle of approximately 60 degrees, the second incision is made, mobilizing the flap now with a pair of dissection scissors with the tips up. Again, you may use a 15 blade or dissection scissors. Be sure to widely undermine this tissue, and again the tissue may be undermined using scissors or a 15 blade. You want it widely undermined so that the flap will be rotated into position so that it is not under any extreme tension. Notice the wide undermining in this particular case. Once the flap and adjacent tissues are widely undermined, then the flap is rotated into position. With the point of maximal tension of the flap here is seen with the first suture. All apices of the flap are then sewn. Here's the first suture at the point of maximal tension. It is at a corner. A corner stitch is not necessarily needed in every case, but you can see how nicely this flap is rotated into position to cover a defect. Now the second suture is placed in again at the apex of the flap, and again it's possible to use a corner stitch if you wish. But in this particular example, we use just a direct interrupted suture technique. And the third apex is now approximated. Deep sutures, if necessary, certainly can be utilized when indicated after adequate hemostasis is obtained. And once all these corner stitches are put into position, then the wound is closed according to the principles of halving. The Z-plasty is useful in lengthening wounds as well as reorienting the direction of scars. In this example, the central limb is 3 centimeters at the start of the incision. The limbs are the same length and both come off at approximately the same angle off the central limb. The angle varies anywhere between 30 degrees and 60 degrees. The greater the angle, the greater the gain in wound length. Any sharper angle or smaller angle results in risk of tip of flap necrosis, while a broader angle results in a difficult rotation. Here the flap is being held out of the way with a skin hook, and the skin is being elevated with a sharp number 15 blade. Each flap is then grasped with a forceps and transposed across so that the central limb totally reorients by 90 degrees in this example. The width of the defect increased from 3 centimeters to start with to 4 centimeters in result, demonstrating the lengthening effect of the Z-plasty. The corner stitches are placed into each flap first to transpose them. Remember, always transpose the Z-plasty. If it closes as it was initially incised, then it will have no effect. The limbs of the Z-plasty are closed with multiple sutures. A geometric broken line closure is utilized to break up a linear scar into irregular shapes so that they are better camouflaged, in that the eye has a great deal of difficulty following these broken lines and therefore makes the scar less perceptible or better camouflaged. The geometric broken line closure is really designed so that each side is a mirror image of the opposite side. Because of the toughness of the pig skin, the geometric shapes here are accentuated, certainly larger than what we would perform on a human in scar revision technique. Here we can see the undermining, and using either a 15 blade or the scissors. Note the double hook, and third instrument, as it were, is the middle finger of the surgeon's left hand, while the scissors are dissecting using the tip upward technique so as not to cut any of the important deep structures. Once these tissues are well mobilized, then the surgeon will try to close the tissue by pushing the tissue together. Deep sutures can be utilized if necessary. There he's trying to close the tissues, and you can see we're now placing the sutures from apex, from peak to valley, and the tissues being well undermined allows the closure to occur with minimal tension. You want to close it with minimal tension to prevent widening of the scar postoperatively. And of course you want the edges to be everted. So a technique is utilized to make sure that these edges are everted. Now you can see how nicely, just with one suture placed, the wound is coming together. And that is because of the wide undermining. Again, the sutures are placed peak to valley, apex of the peak to the depth of the valley, and you can see how nicely this begins to close this pig's foot. The remainder of the sutures are placed peaks to valleys, and then according to the principles of halving. Here's a closer view showing the introduction of the simple sutures to close the geometric broken line closure as a technique or method of scar revision. Here we can see in this particular example the corner suture is being placed so that it does not interfere with the blood supply of one limb of the flap. There the corner stitch is put into position. It now comes out through the skin on the opposite side so that the closure can be made without interfering with the blood supply to the delicate tip where the incision had been previously placed. So there's an example of a corner stitch. And again, that is not necessary at every site. It can be used when you think there's a concern about the blood supply to the tip of the flap. That shows the conclusion of the close. W-plasty is a scar revision technique that's utilized to camouflage scars that are not parallel to relaxed skin tension lines. We use a geometric broken line closure when we have hypertrophic scars that are parallel to the relaxed skin tension lines. So here in this example, we're using a W-plasty, and again, the peaks and valleys are such that the peak on one side corresponds to the valley on the opposite side. The limbs of these W-plasty should not be any greater than 5 to 7 millimeters in length. The angles you can see are not less than 90 degrees. They're broader than 90 degrees usually, or at least 90 degrees. Now we're dissecting the W-plasty by now elevating the skin that's going to be removed, which would be the site of the scar. This is a little bit broader than we would use in the human because of the thickness and toughness of the pig skin. Undermining continues, actually to remove the scar. And again, W-plasty is used to camouflage a scar not parallel to relaxed skin tension lines. Now the scar has been removed. You can see the area of the scar, and now the tissues are well undermined. Again, either a 15 blade or a dissection scissors may be used with the tips pointed upward so that you don't interfere with the underlying vasculature and then have to obtain hemostasis. Now, finger pressure is used to make sure that it can be closed easily. Deep sutures may be placed when necessary, and it's usually best to use deep sutures with a long-lasting life so that they are in position for a long time. Then eventually they may dissolve. This will allow the deeper tissues to be closed and keep the tension off the skin sutures. Here the sutures are interrupted, again from a valley to a peak or from a peak to a valley at the apex. Corner stitches may be used. Here's an example of a corner stitch being used at this site into the dermis to prevent tip necrosis. They are not necessary in every case. And now the second throw is through the skin, and the suture is then tied down to close the wound. Instrument tie certainly may be used, or a hand tie may be used. Always use square knots.